I'm going to go over the definition of a small renal mass, talk about their behavior, the role of biopsy, active surveillance, and then I do want to spend a little time on complex cysts because it's something that we encounter frequently, and I think patients suffer a lot of anxiety sometimes because of that finding. So I want to spend a little bit of time to go over that. So how do we define a small renal mass? There's actually two definitions of it. Typically, a small renal mass is one that is less than 3 centimeters or about roughly the size of a $50 coin. Some, however, do define it as a mass less than 4 centimeters or roughly about the size of a golf ball. Now, this mass may be benign or malignant. Many times we don't really know, and many times, as I will show you, it may not matter. So this is important because this represents, at this point, half of the new presumed kidney cancer diagnoses that we make. And again, a large majority of these might be benign, which in turn means that many patients maybe go unnecessary treatment or surgery and suffer the consequences of those. Yeah, so, back in the 80s, 90s, somebody showed up with a small spot on their kidney. That kidney was in the bucket the next day. So it was a bit aggressive, but we didn't know much, and we were afraid of the disease. But Dr. Bosniak was someone who had basically a vision that maybe these things behave differently based on their size. And what this graph shows you is that first experience that was published that basically showed that when tumors are small, they're invariably all very low grade if they're cancer, and they grow very slowly. And so what that graph is showing you is the number of patients. Each column is a patient or tumor in a patient, and then the growth rate. And you can see that invariably the overwhelming majority of these grew less than 1 centimeter over the course of a year. And in fact, most of them even less than that. And the other thing that we had been learning concurrently and shortly after that is that the risk of spread of kidney cancer is very directly related to its size. So you can't get simpler than that, in many ways. So size in many ways does not completely by itself, but has a very strong influence on the risk of spread. So when we're looking at kidney cancer, not even just tumors, but known kidney cancer that's less than 3 centimeters, the risk of spread is basically less than 1%. And the overwhelming majority of these are low grade, meaning not aggressively behaving. And so with that in mind, many years ago, we actually started our own surveillance program for these tumors based on what Dr. Bosniak and some others had done. And this shows, oh gosh, I think this is 181 patients in our surveillance group that we had. And what this is again showing, it's called a waterfall plot because it looks like a waterfall. And so with the columns going down, it means they're shrinking. With the ones where you're not seeing much of anything, it means they're not changing at all over time. This is over the course of 2 years. And these are for tumors less than 2 centimeters. So incredibly indolent, non-aggressive behaving. And many of them don't grow, some shrink. There is a very small minority of them that do grow a little bit more quickly, which is why we don't just ignore them. We do monitor them for that reason. And so this is an example of a patient that I saw many years ago. Here's a small renal tumor that was seen on initial imaging. And over the course of 7 years, it grew maybe 1 centimeter. Okay. And if this is an older, sicker patient, we've potentially saved them from unnecessary treatment and potentially a complication from that treatment. So again, what we've learned over the course of decades and thousands of patients from the international literature is that the average growth rate for these tumors is 0.3 centimeters per year. So not very rapidly at all. That's average, some less, some a little bit more. About 15% of them will grow more rapidly, which we just very vaguely define as more than 0.5 centimeter per year. And those are the ones that we will generally act on. Now, one thing to point out is that just because it's growing, it doesn't mean it's cancer. We have had known benign tumors that we're monitoring that will grow, and we've had known cancers that we're monitoring and don't grow. So the growth doesn't tell you what it is. So this is just another graph showing you the breakdown of the number that might even shrink or not grow or have very low growth rate versus very small minority of them that tend to grow more quickly. And again, that's why we monitor them to catch these bad, not necessarily bad players, but the ones that could potentially be bad players and intervene on them. So one thing to point out is that imaging cannot tell us if it's benign or malignant. There's one exception, and that's an angiomyolipoma. This is the most common, one of the most common benign tumors of the kidney. If it has a lot of fat component, then we can call it out on the scan and feel very confident about it and tell you not to worry about it. And then there's some other new imaging modalities that reportedly can identify oncocytomas, one of the other more common benign tumors of the kidney, and another one that can tell clear cell, but they're not really reliable. We really have not been using them here. And so really the only way we can tell for sure is to get tissue, either by biopsy or by removing it. That's the only way you can get real confirmation. And even with that, there's maybe a 10% chance with a biopsy, for example, because I'll show you where we might not get it. So, but there are particular populations that we can identify. And this is even something that many urologists don't think about. You'll read on the internet, find a tumor in a patient, 80% chance it's cancer. Well, that's not really true. That's what you put on the news headline if you're trying to keep it simple at a 6th grade level. But really, if you look at it, if I see a patient who's female and she's in her 40s, that patient has about a 50% chance of having a benign tumor. And more than likely, usually these are angiomyolipomas. On the other hand, you see a 70 or 75-year-old man, yeah, that's going to be roughly 80% chance of it being cancer, if not a little bit higher. So gender and age have a large influence on predicting what a patient may have. And then the other thing to point out is that when we follow the survival of patients with a small renal tumor, whether it's treated or not, the likelihood of dying from it is less than 1%, but the likelihood of dying from other conditions during that same time is upward of 45%. Obviously, that depends on the age and health of the patient. But since it is a cancer that's highly related to age and men, both of which are related to less good health than being younger and being female, basically that can have a large influence on things. So we need to monitor these. And I have to remind patients there's no symptoms. The kidney, as many of you, I think, know, the kidney is well hidden. It's way behind the rib cage, surrounded by an envelope of fat. It ain't touching nothing that's going to cause you symptoms. We see patients all the time that go in for something like, say, appendicitis. And then meanwhile, we find a basketball-sized tumor on the left side. Yeah? And so there's really, you can't rely on symptoms. For the first good quality study, we want a high quality CT or MRI. That means that we want it without contrast and with, because that helps us characterize it ideally. We can identify the angiomyolipomas, for example, that way. If it's just with contrast, we may miss that. After that, however, you don't need to get quite as intensive, and it can just be a standard CT or MR with contrast. Ultrasound can be reasonable to use if you show that it's not really changing much. The problem is the measurements always vary depending on who's doing it, on the time of day. And then we routinely do chest x-rays yearly, but many people argue it's kind of a waste because the likelihood of spread is so low, and I can't disagree, but it's hard to change practice because you don't want to feel like you're shortchanging anybody. So why do we use contrast? I know people hate it, but give you a couple of examples. So this is a non-contrast CT. You see sort of a bulge in the kidney. And then what happens is we give contrast, and this is actually like an earlier phase of contrast. And what you see here is that this thing actually turns out as a cyst, but then suddenly we're seeing something here that looks a little funny. And then so their tumor is actually not something that's very visible on the non-contrast, where you get thrown off by this, but really the tumor is this. Here's another example where you see kind of a bulge in the lower part of the kidney. With early phase contrast, what we're seeing is, ooh, there's something weird here, but it's still kind of fuzzy, can't tell what's what. And then after a more delay, now what we're seeing is a very much better defined tumor that's completely within the kidney and essentially camouflaged by the rest of the kidney. You cannot see that without contrast. Maybe on ultrasound you could see it, but it's not going to be as well defined. I had our technician turn the lights down. It's not quite dark enough, but this is what contrast does. If the room was very dark and I asked you to draw an outline of the room and where the tables are and how many people are sitting on each, you might have a hard time to do that in the dark, right? Turn the lights on, right? And then you're going to be able to see. That's basically what contrast does for us. There are some rare cases where we can rely on non-contrast, but asking us to manage a patient without that can be really challenging. And for those patients who can't get contrast, it's a real challenge. Okay, doctor, do I need a bone scan? Why aren't you getting a brain scan? And why are you shortchanging me? Get that all the time. So you all know what a PET scan is. It's not that. It's terrible for kidney cancer with very rare exceptions. Part of the reason is that the injection they gave you, the FDG, is concentrated by the kidney. it's not going to show you anything in the kidney. Everything's going to light up. Okay. There's some rare forms of kidney cancer that will be also avid with FDG, meaning take it up and light up like many other cancers do. Kidney cancer is not one of them that will reliably do that. So no, I will not order a PET scan because your family member had it for some other cancer. Okay, so behavior of small renal masses. Summary, less than 2 centimeter tumors are very universally indolent. I have to tell you, we don't even see them here. We send them to our suspicion of cancer clinic because there's so many that are found incidentally. We can't manage to see those patients and treat the patients who need surgery right away. So thankfully, we have a team that is under our guidance. We'll see these patients and monitor them and then send them to us when appropriate. Tumors 2 to 4 centimeters grow on average 3 millimeters per year. I'll talk a little bit about biopsy, but we consider that roughly around 3 centimeters in size. Growth doesn't tell you what it is. The likelihood of spread is somewhere between 0 and 1%. In older and sicker patients, the risks of treatment probably outweigh the benefits for most of these patients, and we can save them an unnecessary surgery probably for their life. On the other hand, in younger patients, we might need to treat, but there's really no urgency to treatment. If you have a cruise scheduled or there's an anniversary coming up, fine, enjoy it. We'll take care of it after that. Okay, role of biopsy. The American Urological Association has a guideline on when we can consider it. And I'm not going to go over all those details about that. At this point in the current era, the non-diagnostic rate, meaning doing it and not getting a reliable result, is somewhere around 10%, 8 to 14%. It used to be 30%, and you may talk to people who still quote that 30%. Probably does depend on maybe who's doing it to some degree, but at major academic centers, it should be roughly 10% or so, if not less. The likelihood of getting a false positive, meaning it shows cancer, but it turns out it's not, that should be very, very low. But it also depends on how you do it. And I'll show you what I mean by the core biopsy. If a core biopsy is done, we can very reliably have good sensitivity and specificity, meaning catch most of them and identify them correctly. And then also, if by chance we get one of that 10% that wasn't diagnostic, doing it a second time gives you a high chance of making it diagnostic, usually because the person doing it is maybe paying a little bit more attention to it. So here's an example of a patient that I saw several years ago. Elderly patient, has 2 tumors actually, as you can see where the arrows in the right kidney. Kidney function is reduced, so it's not like we have a lot of wiggle room in terms of manipulating the kidney. Does have a lot of health conditions, but they're managed well. And the patient decides that basically they want to watch this for a while. And the question is, do we bother doing a biopsy or not? Is it going to alter anything? Okay, we'll get back to that. This is the other question we get a lot of. Doctor, are you going to spread my cancer when you stick a needle into it? No. So, but I understand there is that popular opinion out there. There's family doctors who tell their patients that don't let them stick that needle in you, they'll spread it. I swear to you, I get these quotes. So probably this crowd, I think, is well versed with this. But no, we don't spread it. We do not really see that in the contemporary literature. Does it happen extremely rarely? Probably. And we do see it very, very rarely at centers, maybe or not even centers, but practices where they're not doing them. Part of the reason it's safe is because it's a very specialized needle. It's called a coaxial needle. You see it here. It's actually a needle within a needle. So it's entirely covered the entire time, except for when it actually gets samples of tumor. But the important thing about that needle is that it gives you an actual sample of tissue. In the bottom, you'll see what's called a fine needle aspiration. In the past, that's all they did. They stuck a skinny needle in and suctioned out what they could, which disrupts a lot of the architecture. And so these core biopsies and doing a fine needle aspiration is the best way to diagnose these. If you only had to do one, you would do a core biopsy. And the worst thing is to just do a fine needle aspiration. And I'll show you why in a couple of minutes. But basically, one of the key aspects of getting a core is that then they can section it into multiple slides and then do all these complex stains or immunostains. And sometimes there's 6 or 8 of them that they do, because then they can reliably diagnose it with all of those immunostains. So that's really important. The other thing that they do is at higher volume centers, they do a real-time assessment for tissue adequacy, meaning, did I get enough tissue just now, or do I need to get another sample? And so there's somebody there sampling it in a way that doesn't waste the tissue at all. But all they're going to be able to say basically is, yes, oh yeah, you have enough here. We don't give a diagnosis, but you have enough. Or they say, oh no, I don't think you have enough. We should probably do some more. So that helps. And so why do a biopsy? Well, quite honestly, if the results aren't going to change recommendations, maybe you don't really need to do it. If we think it's something other than the tumor of the kidney, lymphomas can sometimes show up in the kidney, for example. That's a very good indication to do it. Some patients just want to know. Say, you're not touching me until I know what that is. Okay, that's reasonable. We'll do a biopsy and then let's figure it out from there. The only problem with that is that even if it's small and we're not recommending surgery, once a patient hears the C word, there may be anxiety and that leads to decisions for which there may be regret down the line. Doesn't happen too often with kidney surgery, but it can. Nothing is perfect. And the other reason we definitely want to do a biopsy is if we're considering percutaneous ablation, which I'm not going to discuss today because we are going to have a great lecture from one of our interventional radiologists that's going to go over that. But if we are going to do that, then we definitely want to get a biopsy. Otherwise, we'll never have a chance to know what it is that we treated. Okay, so this is that patient that I showed you. Patient had an FNA and a core biopsy done. The FNA didn't help at all, but the core biopsy showed an oncocytic neoplasm. Oncocytic is really a descriptive term for what the cells look like under the microscope, under basic staining. But when they do additional immunostains on it, they can very strongly suggest or diagnose that it's an oncocytoma. These are benign tumors. So now not only can we put the patient at ease that he's not living with a cancer that we're leaving alone, but also the fact that we likely never will have to do anything. We're still going to monitor it because, there's going to be some anxiety about not looking at it, but the likelihood of us going in and intervening is close to zero. Okay, so then I'm going to talk about active surveillance. This basically means that we're actively monitoring these small tumors, and we do this with these small renal masses or complex cystic masses, which again, I'll talk about at the end. This is part of our guidelines, so it's not anything that's that unique. It should be nationally recognized as an option for appropriate patients. I'm going to skip over that. These are some of the patient and tumor-related factors that we need to look at: age, life expectancy, comorbidities or associated medical conditions. Frailty is a big one. Kidney function is a big one. And also, of course, the tumor has to be appropriate, a small one that isn't rapidly growing. So again, a lot of data, thousands of patients, over a decade follow-up that shows that it's a very reasonable option, at least an initial option for these small tumors in these patients. But it is very individualized. It requires a conversation with the patient about what all the options are. Is it risky to wait and then do treatment later? And the data we have with that is that it's very safe. Overall metastatic potential less than 1%. In our cohort of over 600 patients, 0.3% risk of that. It doesn't appear to limit treatment options or risk progression of the cancer. And again, I've told you this already, that the growth doesn't help us. So how do we do it? Well, if there's only one scan that a patient comes in with, usually we'll get a second one within like 4 months. And that's quite honestly mostly psychological, I'll be honest with you, for the patient, because they don't quite believe you. If someone in the emergency room told them, you need to have this treated right away. So of course we have to now work against some of that, right? So we get that at 4 months, confirm that it's stable, and 98% of the time it is. And then once we show that, then we go to every 6 months. Keep in mind, not all of these things are perfectly round. So imagine if you have something that's oval and you measure it one way, you get one measurement, you measure it slightly different calipers, you're going to get a different measurement. This happens all the time. So unless a radiologist is putting them side by side and measuring them, which is something that I do Sunday nights before every clinic on Monday, then it's going to look like things are growing, but they're not, because they're just measured differently. So that happens very frequently. And it's not unusual. Once every 2 or 3 months, we get a very anxious message from a patient saying, I need to be seen right away. My tumor has grown. They were getting monitored locally. And of course, they show up. I have to print out the images, show them to them by side to show, no, it's just not perfectly round. It was measured differently by different radiologists who didn't bother looking at the prior one. Here's another situation, basically, of an elderly patient who had a stroke. They are incidentally found to have this 2-centimeter mass deep in the kidney. This is not going to be easy to treat. Kidney function is reduced, as is in many of our cases. So it's not like we can just take the kidney out. They're going to suffer significantly from loss of kidney function. Do we do a biopsy? Well, it was done at an outside hospital and read as clear cell kidney cancer. But then we reviewed it here by our pathologists who have specialized training in kidney cancer, and actually shows a chromophobe kidney cancer. And for those of you who may not know, chromophobe is a much more indolent cancer. I describe it to my patients as a reluctant cancer. We've literally taken out basketball-sized ones that never recur. They don't all do that, but most of them do. And so in this particular situation, we just monitored, and sure enough, 2 years later, it's completely unchanged. And then followed with ultrasound, remains unchanged. So to summarize the surveillance, it's a very good initial and maybe even long-term strategy for the vulnerable patient with a small tumor. Biopsy sometimes can help with decision-making, but doesn't necessarily have to be done. The growth doesn't predict the aggressiveness of it. What does predict the aggressiveness of it is how big it is when we first diagnose it. So if it's like a 4-centimeter tumor, that may not be one that we want to watch for very long. And those tend to grow, be more unpredictable. They're more unpredictable in terms of what they will do. Some may not grow, but we can't be as confident with our prediction. Okay, and then finally, I want to go over complex cysts. What does that mean? Well, look, cysts are very common. 50% of the population over age 50 has a simple cyst. They're basically water-filled sacs. Looks just like a balloon, essentially. So very thin wall, and the inside is water. The problem is when you start getting some other stuff in it. If you get like little veils of tissue or nodules of tissue, or if it bleeds inside itself and then there's a blood clot in it, which makes it look funny. So a complex cyst is defined as one that's mostly liquid, but less than 25% of it has some solid tissue in it. And there, Dr. Bosniak again came up with this scale. 1 is a simple cyst. A 2 and a 2F are slightly complex. There's no concern for cancer. When you get to Bosniak 3 and 4, when there's more tissue in it, then there's a higher risk for cancer ranging from 50 to 90%. Oh my God, that sounds scary, right? Well, I'll talk to you a little bit about that. So this is some examples, figures that kind of show you the 2 to 2F. And then when you start getting thick tissue or a thick capsule or rind around it, or you get nodules of tissue, then you get to the 3 and 4. So here's an example of a 52-year-old, so fairly young, very healthy patient, had a 6.6 centimeter cystic mass. This is a non-contrast, just to drive that point home. You see something there, hard to know, but it's with contrast that we can tell reliably that this is actually mostly cystic, but there are these thickened veils of tissue that are in there. And so the one thing about that is that you'll see it's kind of big, right? It's not small. But the risk isn't based on size. It's, water doesn't hurt you, right? It's the tissue. It's what the potential tissue is. So if you crump up all of that tissue in there, it's still going to be a small amount of tissue. So the risk is actually the solid component. And it's the total volume of the enhancing tissue that renders the risk, okay? Not the size of the cyst. It's very alarming for a patient to get a result of a CT scan that there's an 8-centimeter cyst. But that size isn't really harmful, and usually there's no symptoms from it. And then the other thing as we monitor these is not so much it growing because there's water accumulating in it, it's the change in that tissue component. So it may not change in size at all, but if that tissue component suddenly is filling it up, that's more of a concern. And so the one thing that's important to point out, and thankfully finally the radiologists caught on with this, in 2019 when they published an update for this, because what they said was, yes, Bosniak 3 and 4 is 50 to 90% chance of cancer, alarm bells. What they neglected to say, and probably didn't recognize, is that these are incredibly indolent. Okay, so going back to that same small renal mass concept, the overwhelming majority of these are low grade, they're not aggressive. If you treat them, patients do really well. If you don't treat them, patients do really well. Okay, and so this is a graph that shows basically cystic. The solid is a T1A cystic RCC. You see it does great. It does as well as a T1A small renal mass, and a larger cystic RCC does almost just as well as that too. So there's not as much data for this for surveillance of these, but there's a lot that we do. It's just not much published. But basically, most of these grow very slowly. We don't see them spread. And so very reasonable to take one's time, take a deep breath, and weigh the options carefully Sometimes treatment is reasonable to do, and I'll show you that in a second. What about biopsying these? Usually you stick a skinny needle and suction the fluid and look for cancer cells. It's kind of a waste. Not only is it a waste because it doesn't really help, but what happens is you get bleeding from the biopsy, and now it looks even worse because it bled into itself. So I don't recommend it, and it's rare that that kind of intervention helps.